Number 1. Ant-Mandible Suturing in ancient India, Amazonia, and Africa. Picture a deep cut across the forearm in a humid forest clearing. There is no metal staple. There is no curved needle threaded with silk. There is no surgical glue. What there is, instead, is a column of soldier ants marching along the leaf litter and a healer with steady hands. This is the setting in which one of the oldest known wound closure techniques on the planet was performed, and it appeared independently in regions as far apart as the Indian subcontinent, the Amazon basin, and parts of sub-Saharan Africa. The ants used in this technique were not symbolic insects, they were biological instruments. Only species with very large, powerful mandibles could be drafted into surgery. In South Asia, accounts often point to the genus Ecophylla, the weaver ants. In the Americas, the larger Eciton army ants and certain leafcutter soldiers fit the role. In parts of Africa, Dorylus driver ants, sometimes called siafu, supplied the mandibles strong enough to pierce and hold human skin. The procedure itself was direct. The healer pinched the edges of the wound together by hand, aligning the skin so that the cut closed cleanly. An ant was then held above the seam and brought into contact with the tissue. The insect's defensive reflex did the rest. It bit down, locking the wound's two edges between its mandibles. With the bite secured, the body of the ant was twisted off, leaving only the head clamped onto the skin like a tiny disposable staple. Several ants in a row could close a wound the length of a finger. In modern terms, the result is functionally similar to interrupted sutures or a row of skin staples. The mandibles created point compression at regular intervals, the wound edges were held in apposition, and the healing tissue could bridge the gap. The method only worked for shallow skin wounds. Deep wounds, crush injuries, and dirty puncture wounds were a different problem entirely, because the closure was surface level and did nothing for damaged muscle or contaminated tissue beneath. Infection risk in tropical environments was high. Soil bacteria, biting insects, and unclean handling all threatened any open wound. Fast closure reduced further contamination, blocked flies and debris, and shortened the time the patient bled. Compression was the main hemostatic benefit, since the mandibles narrowed the gap and slowed capillary bleeding. Formic acid and other secretions from the ants may have contributed a mild antimicrobial effect, but this should not be overstated. The chemistry was incidental, not the goal. There was no anesthesia. Patient control during placement mattered because flinching could pull the wound apart or drive the mandibles deeper than intended. High-tension wounds, the ones stretched by movement or muscle pull, sometimes tore through the skin between bites. The technique appeared in separate regions because the underlying logic is simple and locally available. Pinch the edges, lock them mechanically, leave them alone. Nature, in this case, supplied a disposable staple thousands of years before surgery learned to manufacture one. But how did people working only with stone tools manage something far more ambitious than a close cut? Number 2. The Liang Tebo Amputee, a 31,000-year-old Stone Age surgery in Borneo. In a limestone cave on the eastern side of Borneo, archaeologists working with researcher Tim Maloney unearthed a skeleton that quietly rewrote part of the story of medicine. The site is called Liang Tebo. The patient was young, likely a child or adolescent at the time of the operation. The lower left leg was gone, removed cleanly, around 31,000 years ago. This is not the kind of damage that animals, falls, or rock falls leave behind. The edges of the tibia and fibula showed the geometry of a deliberate cut. The shocking detail is not the amputation, it is the survival. Bone remodeling around the stump indicated that the patient lived for roughly 6 to 9 years after the operation. The bone healed, reshaped, and adapted to a life without a foot. For the modern reader, this is the central mystery, because survival, not cutting, is the hard part of an amputation. There were no steel blades, no bone saws, no tourniquets in the modern sense. The cutting tools available were sharpened stone, likely flakes of chert or a similar fine-grained material. Sharp stone can cut soft tissue effectively, and a skilled hand can score and snap bone, but controlling the depth of the cut is far more difficult than with a metal blade. The danger sits in the major blood vessels behind the tibia. Severing them without effective hemostasis would mean death within minutes. Shock, blood loss, dehydration, and pain are the immediate threats. The next threat is infection, and the tropical forest of Borneo is one of the most microbially rich environments on Earth. Humid air, abundant insects, and warm temperatures accelerate bacterial growth in any open wound. To survive, the patient needed prolonged aftercare. Someone cleaned the wound, someone dressed it, someone carried the child, fed the child, and protected the child from further injury for weeks or months while the stump closed. That care has a social implication that often goes under-discussed. A foraging group in the late Pleistocene kept a disabled member alive across years. The operation, in other words, was not just a technical event, it was a sustained communal project. Plant-based antisepsis is possible, given the rich pharmacology of Bornean rainforest flora, but the direct evidence is absent and the claim should not be overstated. What the bones show is that a procedure long assumed to be impossible before metal tools and antibiotics happened anyway, and the patient walked away from it, then continued to live. Which raises a second question. If amputation existed 30,000 years ago, what about the dentist's chair? Number 3. Mehrgarh bow drill dentistry. 7,500 to 9,000 years ago in Pakistan. In the Neolithic farming settlement of Mehrgarh, near the Bolan Pass in what is now Balochistan, a team led by Roberto Macchiarelli and Andrea Cucina examined a set of human remains and noticed something unexpected in the molars. 11 teeth distributed across 9 adults carried small, round, deliberate holes. The dates range from roughly 7,500 to 9,000 years before present. These were not natural cavities, they were drilled. Mehrgarh was a community of early farmers and craft specialists. Bead making was a significant local industry. Drillers worked tiny holes through stone, shell, and bone using bow drills, a tool that translates a back and forth motion into rapid rotation. The cutting tip was likely a flint point. The technology required for piercing a hard bead is, mechanically speaking, very close to the technology required for piercing a tooth. Molars are difficult targets. They sit at the back of the mouth surrounded by cheek, tongue, and saliva. The drill had to enter at a precise angle into a stationary jaw on a tooth surface that is harder than any other tissue in the human body. Enamel, in modern materials terms, ranks around 5 on the Mohs hardness scale, harder than steel in some respects. Without anesthesia, drilling enamel should have been intolerable. Once the drill reached the dentin underneath, the pain receptors of the pulp would have been exposed, and any deeper penetration risked piercing the pulp chamber and triggering abscess, yet the procedures appear successful. The drilled surfaces showed post-procedure wear, which means the patients kept chewing afterward, sometimes for years. The drilling may have removed early decay, relieved pressure inside a damaged tooth, or addressed an abscess by drainage. The interpretation is debated, but the mechanical outcome is not. The hole was real, and the patient survived to use the tooth. The likely operator was not a physician in any modern sense. The operator was probably a craft specialist who already drilled beads for a living. Tool familiarity, hand stability, and tactile feedback transferred from one material to another. A bead driller who could make a clean hole through a small shell could, with care, make a clean hole through a molar. In modern dentistry, drilling still relies on the same basic principle, only with high-speed rotary burrs, water cooling, and local anesthetic. The Mehrgarh procedure had none of those refinements. It had a bow, a flint tip, a patient willing to hold still, and a craft tradition that had already mastered rotary work on hard materials. Which brings us to a culture where deliberate control puncture was not a treatment but a public ceremony. Number 4. Maya Stingray-Spine, bloodletting, through the tongue and genitals. In the classic Maya world, blood was not merely a fluid. It was the medium through which rulers communicated with the supernatural, and the act of releasing it was a public choreographed event. The lintels of Yekchilan, especially lintel 24, give us the most famous visual document. Lady Zok, consort of the ruler Shield Jaguar, is shown pulling a rope studded with thorns through a wound in her tongue, the blood falling onto bark paper that would later be burned as offering. The instruments were various: stingray spines, obsidian blades, sharpened bone awls, and thorn-studded ropes all appear in the archaeological and pictorial record. The chosen sites of puncture were the tongue, the earlobes, and, for male rulers, the penis. These tissues are heavily vascularized and densely innervated, which guaranteed both pain and copious bleeding. The point was visible sacrifice. The risk was real. Hemorrhage was a constant danger. Tongue wounds bleed aggressively, and the genital region contains the dorsal arteries that, if pierced uncontrollably, can produce substantial loss. Infection was the second hazard. Oral wounds sit in a microbial environment dense with bacteria, and genital wounds in a humid climate carry their own risks. Stingray spines compound the problem because they carry a venomous coating and a barbed structure that can lacerate on withdrawal. Obsidian, by contrast, has one of the sharpest natural cutting edges known, and a clean obsidian incision produces less tissue trauma than almost any metal blade. The critical detail is that these were controlled punctures, not random lacerations. Maya elite practitioners performed the rite repeatedly across decades. They knew, by procedural tradition, how deep to go, where to enter, and how to manage the aftermath. Ruler survival was politically essential. A king who died of an infected tongue wound was a theological catastrophe. So fasting, ritual washing, isolation, and possible herbal aftercare are all suggested by the broader ethnographic record. The practice continued for centuries across the Maya lowlands. Named individuals like Lady Zoc and Shield Jaguar appear in dated inscriptions, which gives us historically concrete cases rather than vague legend. Blood, in this system, was a political and religious medium, not a clinical treatment. To call it medicine would be to misread it. The body itself became the royal instrument, and the wound was the channel through which dynastic power was renewed. But the same Maya region offers another procedure where the goal really was healing, and the method, while monstrous on the surface, mapped almost exactly onto modern wound science. Number 5. Maggot debridement therapy in the ancient Maya world and Aboriginal Australia. Before antibiotics, an infected wound was an open question. The body might wall the infection off. The infection might spread, become septic, and kill the patient within days. In several parts of the ancient world, healers reached for a strange, deliberate countermeasure. They placed fly larvae directly into the wound. Not every maggot is medically useful. The distinction is critical. Some species, like the screwworm, attack living tissue and produce destructive myiasis, a parasitic disease. Others, like the blowfly species Lucilia sericata, feed primarily on necrotic tissue. The ancient Maya and certain Aboriginal Australian groups appear to have learned, through observation, which larvae to use. Reports also exist of similar practice in Highland Burma and parts of Central America. The mechanism is straightforward. Maggots digest dead tissue externally. They secrete enzymes that liquefy necrotic flesh, then absorb the resulting nutrients. Necrotic tissue, the slough and pus that line an infected wound, is easier to consume than healthy tissue because it is already broken down. The larvae effectively clean the wound surface, removing the dead material that bacteria use as a habitat. Modern wound science has identified several active compounds in larval secretions. Proteolytic enzymes dissolve dead tissue, allantoin and urea contribute to tissue conditioning. Antimicrobial peptides directly suppress bacterial growth. The secretions also alkalinize the wound environment, which is hostile to many of the bacteria that thrive in slightly acidic conditions. Then there is the matter of biofilms, the protective layers that bacteria build to resist antibiotics and immune attack. Maggots disrupt biofilms mechanically as they move and feed. Ancient observers did not know any of this in chemical terms. What they could observe was that wounds treated with the right larvae smelled less foul over time. The pus decreased. The wound edges looked cleaner. The patient sometimes survived an injury that, untreated, would have killed them. Timing mattered. Left too long, larvae could begin to damage healthy granulation tissue, so the treatment had to be removed at the right point. The modern medical version uses sterile, lab-raised Lucilia sericata larvae in controlled dressings, and it remains in active use for diabetic ulcers and other chronic wounds. The effect was always biological, never symbolic. The wound's horror, in this case, sometimes contained its cure, which is a useful reminder before turning to a procedure that targeted the most delicate organ of all, the eye. Number 6. Sushruta's cataract, couching with a curved needle, around 600 BCE in India. Cataract is a clouding of the eye's natural lens. In the ancient world, it was a primary cause of blindness in older adults, and that blindness was effectively lifelong. The Indian surgeon Sushruta, working in the period traditionally dated to around 600 BCE, described a procedure that did not cure the condition, but partially restored sight. The text is the Sushruta Samhita, a foundational work in the history of surgery. The procedure is called couching. The technique did not remove the lens, it moved it. A curved needle made of a metal like bronze was inserted through the sclera, the tough white outer layer of the eye, at a precise lateral entry point. The tip was then advanced behind the iris until it reached the lens. The surgeon then pushed the clouded lens downward and backward, displacing it out of the visual axis and into the vitreous chamber, the gel-filled space at the back of the eye. The eye was now in a condition modern ophthalmology calls aphakia, meaning without its natural lens. With the cloudy lens out of the way, light could reach the retina again. The image, however, was severely unfocused because the lens is what fine-tunes the optical system. Patients could see shapes, movement, light and dark, and large objects. They could not read text or recognize a face from across a room. For someone who had been fully blind, even crude vision was life-changing. The risks were severe. The eye is one of the most infection-prone parts of the body. Endophthalmitis, an infection inside the eyeball, can destroy the eye in days. Retinal detachment was possible if the needle path went wrong. Internal bleeding, glaucoma from disrupted fluid drainage, and chronic inflammation could all follow the operation. Patient stillness was essential because any movement during the procedure risked tearing internal structures. Postoperative care involved rest, head positioning, bandaging, and, in traditional Ayurvedic practice, applications of medicated oils or ghee. Modern cataract surgery removes the lens entirely, often through ultrasonic emulsification, and replaces it with a clear artificial intraocular lens. The optical outcome is vastly superior. Couching persisted in some regions into the 20th century despite known complication rates because it required minimal equipment and could restore at least some sight in settings where modern surgery was unavailable. Sushruta moved the obstruction. He did not move the disease. The same surgical tradition, however, produced something far more ambitious: the rebuilding of a missing nose. Number 7. Sushruta's forehead flap rhinoplasty. Around 600 BCE in India, nose amputation was in several ancient societies a deliberate punishment. It marked the victim for life, and it carried both physical and social consequences. In ancient India, it appeared in legal codes, in stories of battlefield mutilation, and in cases of accused adultery. The destruction of the nose was a destruction of identity. Sushruta's response was reconstructive surgery. The technique began with a leaf-shaped template, often cut from a plant leaf or piece of cloth, sized to match the missing nasal structure. This template was placed against the patient's forehead to plan the flap. The surgeon then cut around the template, but, critically, did not detach the flap completely. A narrow bridge of tissue was preserved at the base, near the bridge of the nose, between the eyebrows. This is the central distinction that allowed the procedure to work. A free skin graft completely detached from the body has no blood supply and tends to die before it can integrate with the wound bed. A flap, by contrast, remains attached at one end. Its vessels keep feeding the tissue while the rest of it is rotated into a new position. The forehead flap was swung downward and folded over to cover the nasal defect. The wound edges of the recipient site were freshened, meaning the scar tissue was trimmed back to expose raw, vascular tissue that could bond with the flap. Sutures stabilized the new nose, but they were not the main reason the tissue survived. Survival depended on continued blood flow through the pedicle at the top. Reeds, or small tubes, were then inserted into the nostrils. These reeds preserved the airway during the swelling phase and prevented nostril collapse as the tissue contracted during healing. Modern anatomical understanding identifies the supratrochlear artery running upward from near the inner corner of the eye as the vessel that supplies the central forehead. The classical Indian flap rode on this vascular territory, even though the underlying anatomy was unknown by that name. Forehead skin is a reasonable color and thickness match for nasal skin, which contributed to acceptable cosmetic outcomes. Risks included infection, scarring along the donor site, and airway obstruction during healing. The technique was reintroduced to European surgery when British surgeons in India observed local practitioners performing the operation. Joseph Carpue, a London surgeon, performed the first documented Western forehead flap rhinoplasty in 1814, after studying accounts from India. The procedure is now known in modern reconstructive surgery as the paramedian forehead flap, and it remains a workhorse technique for nasal reconstruction after skin cancer excision. The nose survived because the blood supply was never fully severed. And the principle of preserving structure under stress brings us to the oldest known systematic manual of trauma surgery. Number 8. The Edwin Smith Papyrus Bone Setting and Splinting. around 1600 BCE in Egypt. The Edwin Smith Papyrus, named for the American dealer who acquired it in the 1860s, is one of the most important surviving documents in the history of medicine. The scroll measures roughly 4.68 meters in length. It is written in hieratic Egyptian and dates to about 1600 BCE, though it is widely believed to be a copy of a much older text. It contains 48 detailed trauma cases, organized in a head-to-body sequence from skull injuries downward through the spine and chest. For each case, the document follows a structured format that would look familiar to a modern clinician. Examination comes first using sight, touch, smell, and tests of function. Diagnosis follows, often described in terms of the injury's mechanical character. Prognosis is then assigned in one of three categories. The case is either an ailment that the practitioner will treat, an ailment that the practitioner will contend with, or an ailment that should not be treated at all. This is one of the earliest known triage systems, and it represents a clear separation between curable and incurable conditions. The text covers fractures, dislocations, skull fractures, and spinal injuries. Splinting is described as the central technique for stabilizing broken bones. The materials are practical and everyday: wood, bark, and linen bandages. The goal is immobilization because broken bones heal through the formation of a callus, a bridge of new bone that requires the fragments to stay in alignment and stay still. Movement disrupts this callus and prevents proper bridging. The Egyptian splint, in this sense, served exactly the function a modern plaster cast or fiberglass splint serves. Failure modes included shortening of the limb, rotation of the bone, angulation, and visible deformity if alignment was lost. Open fractures, in which the bone broke through the skin, carried a high risk of osteomyelitis, deep infection within the bone. Without imaging, alignment had to be judged by feel and by visible limb position. The practitioner could not see what was inside the limb. Honey, mentioned across multiple Egyptian medical papyri, was applied to wounds. Honey has measurable antimicrobial properties through high osmolarity, low water activity, and the production of hydrogen peroxide as it interacts with wound fluid. Linen bandaging added compression and protection. The papyrus represents a tradition that worked best on closed fractures where the skin remained intact and infection was less likely. Skeletal evidence from ancient Egyptian cemeteries shows healed fractures with reasonable alignment, supporting the conclusion that splinting was widely and effectively practiced. The body was treated in this manual as structure, and structural problems received structural solutions. Then there is a procedure where structure itself had to be cut open to save a life or end one. Number 9. Ancient Cesarean section in the Mishnah, Sumerian and Roman law, and early traditions. Obstructed labor in the ancient world was an emergency without good options. When a child could not pass through the birth canal, the mother, the infant, or both would usually die. Several ancient legal and religious traditions describe the surgical extraction of a fetus from the womb, but these accounts need to be read carefully because they cover several different scenarios that modern readers often conflate. The earliest legal codification appears in Roman tradition under the name Lex Caesarea. The law, attributed in legend to Numa Pompilius and refined under later Roman authorities, required that a dying or recently deceased pregnant woman be cut open so that the infant could be extracted. The primary motivation was not maternal medicine, it was concerned with the survival of the child, with burial customs, and with the legal status of the unborn. The procedure was in effect post-mortem extraction, performed on a body that was already lost. Perimortem extraction, performed while the mother was dying but still alive, is a different matter. The Mishnah, the early Jewish legal compilation, contains a passage discussing childbirth that mentions removal of a child through the wall of the womb. Scholars debate the precise meaning of this text. Some readings suggest a real surgical scenario with maternal survival implied. Other readings treat the passage as a hypothetical legal case used to clarify rules about firstborn status. Similar fragmentary mentions appear in Sumerian and Hindu traditions, often woven into mythic birth narratives that should not be read as direct surgical evidence. Live maternal survival on a working anatomical level should have been almost impossible before the modern era. Uterine hemorrhage is the central danger. The uterus contains a dense network of large vessels, and opening it during labor releases substantial blood. Peritonitis, infection of the abdominal cavity after opening the peritoneum, was another near-certain killer in environments without antisepsis. Shock from blood loss and pain would have compounded the threat. No safe anesthesia existed, no blood transfusion was possible, and antibiotics were many centuries away. There are factors that could, in narrow circumstances, support survival. Uterine contraction after delivery reduces bleeding by compressing the vessel walls. Rapid manual pressure could slow hemorrhage. Speed of the operation mattered because the longer the abdomen stayed open, the higher the contamination. If the mother had already died, immediate extraction of the infant gave the only realistic chance of saving the child, and even that depended on extracting within minutes of maternal death. Securely documented cases of mother and child both surviving an open abdominal delivery do not appear in the record until much later, in the Renaissance and early modern periods. Ancient Caesarean section sits in a difficult zone between legal text, emergency intervention, and legend, which leaves one universal technology, blunt but available in nearly every region of the ancient world. Number 10. Cauterization with heated bronze and iron in Egypt, Greece, Peru, and beyond. Bleeding is the most immediate threat in any surgical injury. Bleed too long, and the patient dies before anything else can act. The technology that addressed this threat earliest and most universally was fire. Heated bronze, iron, or any fire-warmed instrument could be pressed against a wound, a severed vessel, an amputation stump, or a tumor, and the heat would seal what the blade had opened. The procedure appears in ancient Egyptian medical texts, in the Hippocratic corpus of ancient Greece, in pre-Columbian Peruvian surgical practice associated with the Paracas and Wari cultures, and in many other traditions across Asia and Africa. Hippocrates is sometimes quoted as having said that what medicines do not heal, the iron heals, and what the iron does not heal, fire heals. Whatever the exact attribution, the underlying logic was widely shared. When other interventions failed, cautery remained. The mechanism, in modern terms, is thermal coagulation of proteins. Heat denatures the proteins in blood, in vessel walls, and in surrounding tissue, causing them to clot and seal. Blood vessels constrict and close. The wound surface is converted into a layer of carbonized sealed tissue. This is emergency hemostasis, and before the development of effective ligatures, vascular clamps, and chemical hemostatic agents, it was sometimes the only practical option for arterial bleeding. The cause was always tissue destruction. The cauterized area is, in effect, a burn. Burns are dead tissue, and dead tissue can become a site of infection if not properly managed. Cautery does sterilize the immediate contact surface because heat kills surface microorganisms, but only at the point of contact. Deeper tissues remain vulnerable. Pain was extreme, and shock from the procedure itself could be fatal. The smell of burning flesh, the smoke, and the depth of the burn all complicated post-operative care. Excessive cautery, applied too aggressively, could delay healing by destroying the very tissue that needed to regenerate. The calculation shifted with arterial bleeding. Pressure and packing could control venous and capillary bleeding, but a severed artery often defeated both. In those cases, the controlled burn of a hot iron pressed against the bleeding vessel was sometimes the only intervention that would buy the patient enough time to survive. The modern descendant of this technology is electrosurgery, in which high-frequency electrical current is used to cut and coagulate tissue with carefully controlled depth and intensity. The principle is the same. Heat seals blood. The control is vastly better. Ancient cautery was crude, but physically logical. Fire saved lives because blood loss killed faster than burns. So if these procedures should not have worked in theory, what is the common thread that allowed them to work in practice? Across 10 very different procedures, the same handful of physical and biological principles keep appearing, and they explain a great deal about why ancient medicine sometimes succeeded. Compression is the most repeated mechanism. Ant-mandibles, compressed wound edges, splints, compressed limb fragments, cauterized vessels compressed under heat, bandages applied steady mechanical pressure. Compression slows bleeding, reduces swelling, and keeps tissue surfaces in contact long enough for natural healing to begin. Immobilization is the second recurring principle. Bones cannot bridge across a gap if the fragments shift. A flap cannot integrate with its recipient bed if it is pulled away. A drill tooth cannot stabilize if the jaw moves unpredictably. Ancient practitioners did not have to understand callus biology or vascular ingrowth to recognize that holding the area still produced better outcomes. Selective removal of harmful tissue is the third pattern. Maggot debridement removed necrotic tissue while sparing healthy flesh. Cataract couching removed an obstruction from the visual axis. Drilled molars relieved damaged or decayed material. The principle in each case was to subtract what was harming the patient without subtracting more than necessary. Blood supply preservation is the fourth principle, and it is the one that distinguishes survival from failure in reconstructive work. Sushruta's forehead flap stayed attached to the pedicle. The Liang Tebo amputation produced a stump that could heal because enough vascularization remained around the cut. Without continued blood flow, no transplanted or repositioned tissue can survive. Fast closure, applied to skin wounds, reduced the time during which dirt and microbes could enter. Some treatments, like maggot therapy and certain plant applications, reduced bacterial habitat directly. Behind all of these principles sits the body's own repair system as the actual healer, the clotting cascade, the inflammatory response, the formation of granulation tissue, the laying down of collagen, the remodeling of bone, the regeneration of mucosa. All of this proceeded without the practitioner's understanding. Ancient medicine at its best assisted these processes rather than producing them. Observation repeated over generations replaced theory. A practitioner did not need to know what bacteria were to know that a foul-smelling wound predicted a worse outcome than a clean-smelling one. Dangerous procedures survived in cultural memory only when their benefits were visible enough to outweigh their failures. Pain tolerance, social control, and the willingness of patients to submit were practical requirements. Elite patients received better aftercare, which biased survival in their favor. Communal nursing in groups like the one that supported the Liang Tebo amputee was itself a medical technology. Tools came from crafts, drills came from bead makers, needles came from leather workers and tailors, reeds came from basket weavers, blades came from butchers and hunters. Failure rates were almost certainly high, and historical memory preserved survivors more reliably than victims. The common thread is not luck. It is partial understanding, applied carefully, repeated until it stuck. But that leaves the largest invisible enemy of ancient surgery, the one the practitioners could not see. Germ theory did not exist before the 19th century. Ancient practitioners had no concept of microorganisms, no microscopes, and no way to identify bacterial species. What they did have was observation. Infection was visible in smell, in pus, in fever, in swelling, in redness, and in delayed healing. The signs of a wound going wrong were obvious, even if the cause was not. Foul odor in particular served as a practical diagnostic. A wound that smelled rotten was a wound headed for trouble. Egyptian, Greek, and Mesoamerican medical traditions all note the importance of monitoring wound smell. Dead tissue, the slough of necrotic flesh, was recognized as dangerous, even without knowing that it served as bacterial food. Several ancient materials carried genuine antimicrobial activity. Honey, used widely in Egyptian medicine, is hygroscopic, acidic when diluted, and produces hydrogen peroxide on contact with wound fluid. Plant resins, including myrrh and frankincense, contain compounds with antibacterial properties. Wine and vinegar, both used as wound washes in the Greek and Roman traditions, contain alcohol and acetic acid, both of which suppress bacterial growth. Certain oils carry mild antimicrobial fractions. Ant secretions contain formic acid, which is chemically active but not magically sterile. Maggot therapy was an infection control method that worked through cleaning rather than chemistry. Cautery sterilized the surface in contact with the hot instrument, but only there. Sealing a dirty wound, by contrast, could worsen infection by trapping bacteria inside. Drainage, although rarely described as a formal principle, appears implicitly across many ancient practices. Wounds were often left partially open, packed loosely, or dressed in ways that allowed fluid to escape. Dry bandaging was, in most cases, better than wet, contaminated dressing. Tropical environments with their high microbial load increased every infection risk. Mouth wounds, sitting in a saliva-rich, bacteria-rich environment, behave differently from skin wounds on a dry arm. Post-operative care, in many cases, mattered more than the operation itself. A skilled surgeon and a careless caretaker could still produce a dead patient. Ancient healers could recognize a worsening wound. They could not always stop it. The word clean in this context probably meant visually clean, not sterile. Procedures worked best under narrow conditions, on selected patients, in environments where some accidental control of microbial load was possible. Infection was the major hidden villain of every operation discussed so far, and ancient success often came from accidentally weakening it rather than understanding it. The tools and materials that did this work were not specialized medical equipment. They came from somewhere else entirely. Surgical innovation, in nearly every ancient case, grew out of available craft technology. The instruments were not designed first for medicine. They were repurposed from the everyday material culture of the society. The story of ancient surgery is to a significant extent the story of which tools were already lying around. Flint was sharp enough for drilling and cutting, and it held an edge that could be resharpened easily. Obsidian, a volcanic glass, produced cutting edges measured at the molecular level, sharper than most metal blades when freshly fractured. In Mesoamerica, obsidian was widely available and widely used. Bronze and iron, in their respective ages, served as cautery materials because they could hold heat long enough to make controlled contact with tissue. Linen, woven for clothing and bedding, became surgical wrapping, compression, and stabilization. Reeds used for baskets and mats became nasal stents in Sushruta's Rhinoplasty. Bark, wood, and small branches became orthopedic splints with minimal modification. Ants and fly larvae served as living biological instruments recruited from the local fauna. Stingray-Spines, used in fishing and as defensive weapons, became Maya ritual blades. Curved metal needles, related to the leather needles and embroidery needles of textile work, became Sushruta's couching tool. Bow drills, fundamental to bead making and fire starting across many regions, became dental drills. Tool familiarity reduced procedural risk. A practitioner who had drilled 1,000 beads had developed the hand stability, the depth control, and the tactile feedback to manage a similar operation on a tooth. Anatomy in many ancient societies could be learned through hunting, butchery, and battlefield experience. Soldiers and surgeons sometimes overlapped. Hunters knew where the major vessels of a deer ran, and that knowledge could transfer to a human limb. Reusable tools, however, carried a permanent infection risk because cleaning methods were limited to washing, rinsing, and occasional heating. Fire served as both tool maker and direct wound tool. Materials shaped by fire could later be applied through fire. The material constraints of the ancient world were drivers of creativity rather than obstacles to it. Practitioners worked with what existed, and they invented procedures that fit the available toolkit. Ancient medicine, in this sense, was built from the technologies people already had in their hands. So how exactly did this body of practical surgical knowledge develop over time? No single explanation accounts for all 10 procedures described in this account. The development of ancient surgical knowledge is best understood through several overlapping theories, each of which captures part of the picture. The mainstream view, held by most historians of medicine, emphasizes trial, error, and the visible outcome. Practitioners attempted procedures, observed what worked, and discarded what did not. Successful cases were imitated. Knowledge accumulated incrementally across generations. Wounds, animals, tools, and healing processes were observed repeatedly, and patterns emerged. This view stresses practical adaptation rather than hidden modern science. It explains why similar procedures, like ant suturing, appear independently in widely separated regions. The underlying logic is simple enough that any sufficiently observant group could discover it. The archaeological and historical view emphasizes the social structures that produce specialists and preserve knowledge. Crafts and ritual offices in this reading generated the operators who became healers. Bead drillers became tooth drillers. Priests who already managed bloodletting rituals accumulated procedural knowledge about controlled injury. Battlefield medics who dealt with the same kinds of wounds repeatedly developed reliable trauma protocols. Midwives accumulated obstetric knowledge across long careers. Elite courts like those of pharaonic Egypt or classical Maya kingdoms preserved procedures through formal training, sometimes through written texts like the Sushruta Samhiti or the Edwin Smith Papyrus. This view emphasizes social systems for the transmission of knowledge, including apprenticeship and textual tradition. The fringe and speculative view raises the possibility that some traditions preserve experimental lineages now largely lost to the historical record. This is not the claim that ancient civilizations had advanced modern technology. The more grounded version of this argument suggests that regional plant pharmacologies, oral traditions, and folk antiseptic practices may have contained more technical detail than the surviving record indicates. Oral traditions, in some cultures, preserve specific procedural detail across many generations. Some scholars working on ethnobotany have documented contemporary indigenous knowledge of plant antimicrobials that may extend back centuries or millennia. The speculative move is to suggest that the record we have systematically underrepresents these traditions, especially those held by communities without writing. Speculation, to remain useful, has to stay grounded. Absence of evidence is not proof of advanced surgery, and dramatic claims require physical confirmation. The genuine evidence is what survives: healed bones, drilled teeth, written papyri, carved lintels, and legal texts. These three theories, mainstream observation, archaeological transmission, and the cautious preservation of folk knowledge, are not mutually exclusive. They describe different mechanisms operating in parallel. Ancient surgical knowledge developed through a combination of careful observation, social specialization, and the slow accumulation of practical intelligence under extreme pressure. Which leaves one final question about what all of this actually adds up to. These procedures, by every reasonable expectation, should not have worked. Many only worked in narrow circumstances, on selected patients, under conditions that an ancient practitioner could partly control but never fully understand. Survival did not equal safety. Success often depended on patient selection. Deep wounds, dirty wounds, weakened patients, and complicated cases very likely died at rates we cannot now measure. The historical record preserves survivors in high-status cases more reliably than failures in ordinary deaths. This is survivorship bias in action. What remains, when this is taken into account, is the body's own repair capacity: clotting closed bleeding vessels, inflammation cleared infected tissue, granulation tissue filled in wound beds, callus-bridged broken bones, vascular ingrowth supported transplanted flaps. The body did most of the work. Ancient techniques helped by aligning with these processes rather than fighting them. Ant-mandibles closed skin so that the underlying clotting and granulation could proceed. Splints stopped motion so that callus could form. Maggots removed dead tissue so that healthy tissue could regenerate. Forehead flaps preserved blood flow so that transplanted skin could survive. Cautery stopped bleeding so that the patient lived long enough to heal. Couching cleared the visual axis so that the retina could receive light again. Drilling relieved damaged teeth so that pressure and decay could be addressed. Amputation required aftercare more than cutting. Ritual procedures like Maya bloodletting survived through control, repetition, and the protection that elite status gave to their practitioners. These 10 cases, taken together, do not show that ancient people were secretly modern. They show something more interesting. Practitioners working with stone, wood, bronze, linen, and living insects, without microscopes, without anesthesia in the modern sense, without antibiotics, and without germ theory, nonetheless touched real biological principles. They did so by watching carefully, by repeating what worked, by training successors, and by accepting that some failures were the cost of any procedure. Ancient medicine worked when observation accidentally touched the fundamental laws of anatomy, physics, and healing. The laws were always there. The procedures were the slow, patient, sometimes brutal discovery of how those laws could be made to serve a patient who needed to survive the night.